Welcome to While We Were Distracted, the podcast where we explore topics that often get overshadowed in the rush of daily life. Please take a moment to like and subscribe. It really helps.
Welcome to the deep dive.
Great to be here.
We're tackling some, well, pretty dense source material today. It's excerpts from a big legislative document.
That's right, a PDF called Billisto 119 HR 1arch.pdf.
Yeah, and it's huge. It covers, everything from immigration fees, federal retirement stuff, to oil and gas leases, really wide-ranging.
But you asked us to do something specific, to really hone in on the healthcare pieces.
Exactly. Pull out the key bits about Medicare and Medicaid changes that are kind of buried in there.
So that's the mission for this deep dive, right? Cut through all that legislative text.
We want to give you a shortcut, basically. Help you find the signal in the noise without reading hundreds of pages yourself.
Think of it as us navigating your sources with you, finding the healthcare stuff.
All right, let's dive in then. Where do we start with the healthcare provisions?
Well, the Medicaid sections really jump out first. They're mostly grouped under Title IV, the Committee on Energy and Commerce part. Subtitle E, specifically health.
Okay, and what's the main theme there? What are they getting at?
There seems to be a real focus on, let's say, program integrity and eligibility rules.
How so? What kind of specifics did you see?
Well, for one, the source mentions additional Medicaid provider screening requirements.
Provider screening. So, checking out the doctors and clinics more thoroughly.
Seems like it. Suggests maybe more stringent checks before providers can join Medicaid. Probably aimed at, preventing fraud or waste.
Makes sense. And you mentioned integrity. Did that connect to payments, too?
Yes, definitely. There's a provision flagged in the text about removing good faith waiver for payment reduction related to certain erroneous excess payments under Medicaid.
Whoa, okay. So if a state overpays, maybe they have less leeway to avoid penalties, even if it was an honest mistake? Less flexibility?
That seems to be the implication, tightening up on payment accuracy.
Was it just general payments, or did they get more specific?
Oh, quite specific in places. One section aims at ensuring accurate payments to pharmacies under Medicaid.
Pharmacies, okay.
Yeah. It talks about changing how drug cost calculations are done. And interestingly, it even sets aside money for the HHS Inspector General to study this whole area.
So real focus on the pharmacy payments. What about managed care? That's a big part of Medicaid now.
Address that too. Section 44124, I think it was. It requires the contracts states have with these managed care organizations to meet specific requirements. Another layer of rules there.
So it feels like they're looking at integrity from multiple angles. Provider checks, payment rules, pharmacy costs, managed care contracts.
Exactly. A multi-pronged approach described in the source.
Okay, let's shift to eligibility then. That's always huge for Medicaid. What did the source say there?
One thing that stood out was a proposal to increase how often eligibility is checked for certain people. Redeterminations, they call them.
So people might have to prove they still qualify more frequently?
Potentially, yeah. Which could, impact whether someone stays continuously enrolled if there are hiccups with paperwork or timing.
What else on eligibility?
There's a mention of the home equity limit, specifically for qualifying for long-term care services under Medicaid.
Ah, right. How much your house is worth.
Exactly. The text says the limit under a specific part of the Social Security Act, Section 1917, would apply. So that could affect who qualifies for nursing home care or similar services paid by Medicaid.
That definitely touches on vulnerable populations.
It does. And speaking of eligibility, there are a couple of sections, 44110 and 41111, that deal with eligibility for aliens.
Okay, how does the source describe those? This can be sensitive territory.
It is. And just to be clear, we're reporting what's in the document.
Yeah.
Section 44110 proposes prohibiting federal Medicaid and CHIP money from going to states that cover comprehensive benefits for aliens who aren't qualified aliens or otherwise lawfully residing here.
So restricting federal funds based on the immigration status of who the state covers.
That's what the text proposes. And Section 44111 goes further, reducing the federal match rate, the FMAP, for states that do provide that kind of coverage.
So a financial disincentive for states, as described in the source. We're just laying out what the text says here, not taking a stance.
Absolutely. Another eligibility change mentioned is about retroactive coverage.
Oh, right. Like getting coverage for bills from before you were officially approved?
Exactly. Currently, Medicaid can often cover a few months retroactively. This source proposes modifying retroactive coverage, which could mean changing that look-back period.
Which might leave people with bills if their application takes a while.
It's a potential consequence, yeah.
It's interesting how some of these details are almost hidden. You mentioned provider screening earlier.
Right, and tucked into that same area, The source adds requirements for states to improve their systems for verifying residency, making sure people actually live in the state.
How?
It talks about disenrolling people who move out, preventing enrollment in multiple states, and even using things like mail returned to the state P.O. box to check addresses, using reliable data sources.
Wow. Well, that's getting down into the weeds of state administration.
It really shows the level of detail in this kind of legislation, trying to plug perceived holes.
Okay, so that covers a lot on Medicaid operations and eligibility. Did the source material mention any specific limits on what Medicaid funds could be used for?
It did, very specific in one case. Section 44125 outlines a prohibition on federal financial participation for certain medical procedures.
Which procedures?
Well, the text lists procedures related to sex and sex changes. It defines sex based on the reproductive system for these purposes.
So, proposing to exclude federal funding for those specific services under Medicaid.
That's what the text states. It does note, interestingly, that procedures to alleviate mental distress wouldn't be excluded by this specific prohibition, according to the source description.
Okay, important nuance there. Any other prohibitions?
Yes, another one targets specific entities. Section 44126 says federal Medicaid funds, the direct spending part, couldn't be used to pay prohibited entities.
And does it define who those are?
It does. It mentions covered organizations like certain managed care plans or prepaid health plans would fall under this restriction. Again, it seems aimed at controlling where the federal dollars go.
Gotcha. So specific rules about services and about who gets paid.
Pretty much sums up those prohibitions as laid out in the source.
All right, let's shift gears a bit, because the source wasn't only about Medicaid rules, right? There were other health-related bits, some in different sections entirely.
That's right. Even within that main health subtitle, there was a reference, section 44121, to a specific rule on minimum staffing standards for long-term care facilities.
Ah, nursing home staffing. That's been a big topic.
Exactly. And it even points to a specific Federal Register publication from May 10th, 2024. So connecting this bill to existing or proposed regulations on quality of care and transparency in those facilities.
Okay. And then didn't the source jump over to, like, tax policy related to health?
It did. Later in the document, under Title X11, the Ways and Means Committee part, there's a whole section, Part 3, called Investing in Health of American Families and Workers.
And what's in there?
A few things focused on employer benefits and savings accounts. For instance, it discusses health reimbursement arrangements, HRAs, and how they work when integrated with individual health insurance. Details on exceptions, different rules for different employee classes.
Sort of tweaking the rules for those employer-funded accounts.
Right. And then there's a proposed employer credit for choice arrangements.
A tax credit? For what kind of arrangement?
The text describes it as a credit for employers offering these specific choice arrangements. It even gives dollar amounts $100 per employee per month the first year, $50 the second year.
As long as it counts as minimum essential coverage, so a direct financial nudge for employers.
Precisely. A tax incentive.
What about things like HSAs, health savings accounts?
Mentioned too, Section 19203 deals with direct primary care service arrangements.
DPC, yeah. Paying a monthly fee to a doctor.
Right. And this proposes allowing those fees to be treated as medical expenses for HSA purposes.
Oh, okay. So you could use your HSA funds to pay that DPC fee, potentially.
That's the idea. It defines what qualifies as a DPC arrangement, lists services that don't count, like hospital care or surgery, and sets caps on the monthly fees, $150 for one person, $300 for a family, according to the text.
Interesting. Making DPC more HSA friendly. What else in that tax section?
Wellness programs got attention. Section 110204 sets percentage limits on how much incentive employers can offer linked to the cost of coverage.
Limits on wellness incentives.
Yeah.
Like for hitting activity goals or getting screenings?
Yeah. 50% for programs tied to health outcomes, 75% total incentive value. It lists eligible activities too, physical activity, nutrition counseling, screenings, that sort of thing, adjusting the rules there.
And any other HSA-related changes?
One more notable one, Section 10205. It allows people to make a one-time transfer, a qualified distribution, from a health flexible spending arrangement or an HRA into an HSA when they first become eligible for one.
So moving money from an FSA to an HSA, up to a limit.
Exactly. Adds a bit more flexibility between those account types.
Seems like a lot of fiddling with health-related tax rules.
It does. And there's one broader tax change mentioned, Sec 110207, that could ripple into healthcare. It changes how companies handle research and experimental or R&E expenses.
How so?
Instead of deducting them immediately, the source says companies would have to amortize them, spread the cost over 5 or 15 years.
That would definitely hit, say, pharma companies or medical device makers, wouldn't it? Changes their R&D accounting.
It certainly could impact their tax planning and maybe investment decisions. It's not just healthcare, but a big impact, though.
Okay. Any other tax incentives specifically for healthcare providers?
Yes, one stood out for rural areas. Section 1111-4 offers an enhanced tax deduction for certain hospitals.
Which ones?
Rural emergency hospitals and critical access hospitals that convert to become rural emergency hospitals.
Supporting that specific model of rural care.
Seems like it. But they have to meet requirements, like doing a community health needs assessment. So a targeted tax break to encourage that type of facility in rural settings.
Got it. And you mentioned Medicare earlier. Did we see much about that in these excerpts? The original request focused on Medicare and Medicaid?
We did find some Medicare points later in the source, yeah, particularly around Medicare Part D, the prescription drug benefit.
Okay, what stood out there?
There was a proposal related to the drug price negotiation program. It looked like it aimed to expand or clarify the exclusion for orphan drugs for rare diseases from that negotiation process.
Oh, potentially shielding more orphan drugs from negotiation under Part D.
That appeared to be the direction in that section, yeah.
And anything else on Part D? It's such a complex area.
Definitely. A lot of focus on pharmacy benefit managers, PBMs.
The middlemen. Always controversial.
Right. And the source lays out requirements for PBMs to report much more detailed information about their costs, fees, rebates, and spreads to the Part D plan sponsors and to the government, to CMS.
More transparency required from PBMs.
Seems to be the goal. And it backs that up by appropriating funds for enforcement and oversight related to PBMs. It even calls for studies by the OIG and GAO government watchdogs to examine pricing across the whole drug supply chain. PBMs, pharmacies, plans, the works.
So really trying to shine a light on how money flows through the Part D system, especially around PBMs.
That's a fair summary of those sections, yes.
Okay, wow. So pulling this all together, this deep dive into the source material, really shows how scattered these healthcare provisions can be, doesn't it?
Absolutely. You've got major Medicaid rule changes, Medicare Part D tweaks, PBM oversight, and then all these tax code adjustments impacting health benefits and providers, all within the same broader bill excerpts. Not neatly packaged at all.
If we try to connect the dots, what are the big takeaways?
Well, the proposed changes we pulled out really hit fundamental parts of public programs, especially Medicaid. Who's eligible, how providers get paid, how states run things, even what specific services get federal funding.
And at the same time, you see the tax system being used as a lever.
Definitely. To encourage certain employer health plans, like those choicey arrangements or DPC integration with HSAs, to promote wellness programs, and to give financial help to specific providers like rural hospitals.
And none of this is just, abstract legislative theory. This is stuff that could actually change your healthcare experience.
Right. The rules described here could directly affect your access to care, maybe the kind of insurance your job offers, or even whether your local rural hospital can keep its doors open or offer certain services. It impacts the finances of providers you might use.
We've really tried to pull out those specific threads: Medicaid, Medicare Part D, the tax investments from this, very large and complex piece of source text you shared.
And what's striking, I think, is just how granular it gets.
Yeah, the level of detail is incredible, down to defining specific medical procedures for funding purposes, putting exact dollar amounts on tax credits, spelling out PBM reporting fields.
It's policymaking at a very, very fine-grained level sometimes.
So this deep dive really highlights how interconnected everything is in one legislative document and the very specific ways these proposals aim to shape healthcare.
It definitely paints a picture of proposed changes across multiple fronts.
Okay, so here's a final thought to leave you with, something to maybe chew on. We've seen all these different pieces: Medicaid rules, eligibility tweaks, service limits, tax breaks, PBM rules. How might all these individual changes, if they happen together, actually reshape the whole healthcare system, especially thinking about, say, vulnerable groups, people in rural areas, or even just the everyday interactions between patients, doctors, and insurance?
A lot to consider there. Thanks for joining us for this deep dive into your sources.
Please take a moment to like and subscribe. It really helps.